Thank you so much, Joy, and thank you to 2020 Mom. Uh, Good afternoon, everyone. I am delighted to see over 200 participants here for this really important conversation. It is around the lunch hour on the West Coast where I am, and I know it's heading into later afternoon on a Friday in other parts of the country. So again, just thank you for sticking with the program because we have a lot of great work and opportunity to share with you today. As Joy mentioned, I'm Elizabeth Krause. I use she, her pronouns. I am your moderator today, and I join you from my home office in Seattle, Washington. I am director at Perigee Fund, but my most important job is that of mom to twin boys. Perigee Fund is a relatively new philanthropic organization that focuses on prenatal to 3 mental health. To us, babies embody both our nation's inequitable past and our more hopeful future. And there are no babies and toddlers and young children without parents and primary caregivers. So in supporting families, especially those furthest from equity, and especially supporting their mental health and emotional well-being, we see an unparalleled opportunity to disrupt intergenerational transmission of trauma and poverty at family and community levels. Perigee Fund has a special interest in the role that policy opportunities play in supporting families. I'm going to set a little bit of background before we launch into the panel. As they say on Sesame Street, at least they said this when I was a kid and when my children were young. I hope they still say it. This slide deck is brought to you by the letters M and H. M and H for maternal health and for mental health. Next slide, please. So maternal health is what I like to think of as a Trojan horse opportunity for us to advance maternal mental health policy. Maternal mental health is the most common complication of pregnancy. And so by supporting some of these opportunities that have either passed or that we need to push over the finish line, we have an opportunity to either directly or indirectly also advance maternal mental health. So for example, paid family leave is associated with a decrease in maternal depression. It does so many other good things too, but this is a way for us to be part of an intersectional coalition supporting policy movement that is good for families and that also supports maternal mental health. Same with postpartum Medicaid extension and the new state option. This will make affording mental health care, should it be needed in the year postpartum, more accessible and affordable to birthing people, but we'll do so many other things for them as well. And as other speakers have talked about over the course of the conference, we also know that some states may not be the first to adopt the state option, may not adopt it at all. And we need to do more as advocates and policy wonks to make sure that we don't leave those moms and babies behind. Next slide. So if we are to open the little hatch in our Trojan horse and get out and actually lead with a message of maternal mental health through policy change, we wanted to raise up a couple opportunities for you to be aware of. The first is the Moms Matter Act for Black and minority mental health. We know that almost all birthing people are not well seen and served or sufficiently seen and served by our current systems, but for Black moms, for BIPOC moms, and for birthing people who are in BIPOC communities, there are additional barriers. And so this act gives us an opportunity to better meet their needs in our quest for equity. And then coming in May, super exciting, the Into the Light for Maternal Mental Health Act has 3 provisions that would address increasing access on the spectrum from peer support to psychiatric support, as well as putting into place prioritization of maternal mental health across different agencies. Next slide, please. So our aim for today's session is to, what we just covered, help the audience understand high-level maternal mental health policy and the context for our conversation. An understanding of federal opportunities, especially as we move into the Biden-Harris administration, and to understand what was happening before the change in administration and what our opportunities are now. We want to help you to understand the unfinished business that we need to pursue. We have over 200 engaged advocates, all with personal stories and motivation here. And we all have a part to play in what still needs to be introduced or passed. And then finally, we want to know what's happening where the rubber meets the road. In different states where people, everyday moms and families get better support. So with that, we can take down the slides, and I'll be pleased to introduce our panel members. All right, our panelists today.
Elizabeth, I think we lost your mic. Elizabeth, are you able to hear us? We've lost your sound. I think your mic has gone out. Elizabeth, please try again.
And we'll go ahead and ask our panelists to
Can people hear me?
There we go.
Okay. The tech gremlins, I cannot explain that, but I'm glad that you can hear me. Our panelists today are Dr. Ben Miller of the Wellbeing Trust, Isha Wirensingi from the Center for Law and Social Policy, or CLASP, Micah Whitfield of PSI Georgia. Micah is also a 2020 Mom Fellow, and Bree McLaurin of Healthy Mothers, Healthy Babies, Montana. Unfortunately, Dr. Dorothy Fink of the Federal Office for Women's Health had to withdraw from our panel and will not be able to join us today. So I'm going to start with the softball, just the panelist introductions. So if each panelist could give their name, rank, and serial number, an overview of your organization's work, and maybe tell us something about your primary motivation for being involved in mental health policy work. So we'll go Ben, Isha, Micah, and Bree.
Wonderful. All right. Thank you. My name is Ben Miller, as was mentioned. I'm currently live in Chattanooga, Tennessee.
And Ben, now we're having trouble hearing you.
Okay.
No, Ben is good. Thank you. Yeah. Please proceed.
Okay, keep going. All right. I live in Chattanooga, Tennessee. I'm a clinical psychologist by training. I'm a musician at heart, so that music break was just lovely. And the Chief Strategy Officer for Wellbeing Trust, which I'll talk about in just a second. I've spent most of my life trying to find ways to better integrate mental health into community and clinical settings, something that I think we'll talk a lot about today for policy. But really, truly, it's about applying what I think of as more like punk rock principles to health policy, which is kind of exciting. If you're not familiar with Wellbeing Trust, we're a national foundation focused on advancing the mental, social, and spiritual health of the nation. We were started by the Providence Health System about 5 years ago, and we aim to take on daunting topics like deaths of despair, which does sound quite daunting on a Friday afternoon. These are deaths to drug, alcohol, and suicide, and we apply unique methods to bring about change for mental health. Things like social movement principles, or by creating frameworks for excellence, framework that recognizes the importance of community conditions, that gives us a foundation for how we can achieve overall mental health and well-being. It sees the need for robust coverage so that we can have affordable and comprehensive benefits, something that you all have talked about, and a framework that really pushes for integration, a word that I'll probably say 100 times today, whether that be care that's given in school, a primary care practice, a prison or workplace, wherever you show up with whatever you need, you should have that help. So we invest in those solutions that bring us closer to that integrated vision. It's an honor to be with you today, and I look forward to our conversation.
Good afternoon, everybody. I am Isha Warasingha. I use she, her pronouns, and I work at CLASP, the Center for Law and Social Policy. We are an anti-poverty organization. We've been around for over 50 years, and we work on policy and advocacy solutions for people living with low incomes. We work on the local, state, and federal levels, and I lead the mental health work across the organization. Our work in mental health focuses on maternal mental health and also on youth and young adult mental health. And our work also centers racial equity, which I'll speak more about, and then also centers the voices of lived experience. I forgot to mention, I'm based in DC, Washington, DC, otherwise known as Nacotchtank, Piscataway, and Anacostan land. And something fun about me is I also love music. And my first concert was at the age of 8, going to see a Peter, Paul, and Mary concert, actually here in near DC.
Hi, I'm Michael Whitfield. I am a survivor, a mother of 2, and I serve as the Vice President for Postpartum Support International Georgia chapter, which is a mouthful, but we, of course, PSI is a leading nonprofit organization around perinatal mood disorders, one of the leading rather, and our mission is to promote awareness, education, prevention around perinatal mental health issues affecting moms in Georgia. So I do that in a volunteer capacity. And then as my full-time job, I work with 9 to 5, which is a National Association for Working Women, where we work on a lot of key issues that overlap, like paid leave and pay equity and things that affect moms. So I've been advocating at the state legislature for quite some time, and really enjoy this work. And it connects deeply to me because I am a survivor.
Bree? We may have lost Bree. Okay, we will let her do the introduction when she's able to rejoin us. First, we're going to start with a question for Ben. Ben, will you help us to get a sense of the mental health momentum prior to COVID? So we'll talk right after about how COVID has evolved the conversation, but where was their energy? What has passed that we should be thinking about? And while some of the policy movement might be broader than maternal mental health, what are the implications for maternal mental health?
Yeah, I love the question, and thanks for giving me such a big area to play in here. If you do anything in policy, inevitably it always comes back to coverage, because within the purview of Congress, you think about what can they and can't they do. A lot of it just really stems on, directing the Centers for Medicare and Medicaid to provide some type of coverage options for people. And so I'll put it into 3 buckets, and then I'll talk into each one of them. There's care, which is something I know we all really do want to prioritize, like what delivery looks like. There's coverage, and then there's community. So let me start with care and just give some high-level context here. People have been calling out for help for a long time. Treatment's been relatively elusive for most folks who have needs. And in reality, if you look at things like substance use disorder, only about 1 in 10 people actually receive recommended treatment. And according to one survey that was done by our friends at Kaiser Family Foundation, only about 40% of American adults, I shouldn't say only, 40% of American adults have delayed seeking some type of care because of concerns about cost. And that's, to me, just like speaks to so many of the problems that we're facing as a nation. And one of the cruelest ironies, which I think will come up as a theme here today, is that the more problems that people have, or the more in need or dire need they might be in, the harder they have to work. And so we have a major problem in trying to actually meet people where they are when it comes to mental health. That was a focus before COVID. Now, we didn't do a great job in policy getting there. Let me tell you a little bit more about the coverage area, because I actually think that's the area that we did talk about the most. So prior to COVID, much of the policy landscape was really about how to enforce mental health parity. And if you're not familiar with mental health parity, which I'm sure many of you are, it's basically a law that was passed over 11 years ago that says that your mental health should be treated at the same level as your physical health. Now, that's an oversimplification. But basically, it's that health insurers are required to cover the benefits of mental health at the same level as they do medical or surgical benefits. The problem is, in an analysis that we did of 32 states and how well they are actually enforcing that law, is that, we did an analysis of all the states, but 32 states actually failed in their enforcement of mental health parity. So 10 years into a federal law, we still had states that were not enforcing this amazing piece of legislation that actually helped people get more care through more robust coverage. So while this is an ongoing problem, states are actually stepping up to fill the gap. And this was a theme that we saw before COVID, where states would say things like, well, we're not enforcing parity. How can we help the folks on the ground that are suffering actually have their benefits do what they're supposed to do? And so they would pass pieces of legislation that really helped enforce parity. Last thing I'll say here, and then I'll be quiet on this topic, which is really, really super important for us, is that when we consider the lack of attention that mental health was getting prior to COVID, and again, I'll talk about COVID in just a second. I'll give you one data point here. We went and ran the tape of the approximately 30 hours that was spent debating in the Democratic primary, just to see how did all these amazing, talented folks who were passionate about healthcare, how much time did they spend talking about mental health and substance misuse? And if we were in a big room, I would ask you to yell it out here, but it was roughly about 5 minutes in total. 5 minutes out of 1,800 minutes total. Not even a full percentage point do we have mental health being a talking point. So this lack of attention in public forums translates into a lack of action for policy. And the last thing I'll say, and I'll be quiet on this one, is that we believe that because of some of the problems that we were already dealing with, like deaths of despair, just to give you some ideas here, 72,000 people lost their lives from drug overdose in 2019, which was a 5% increase from the year before. And 2020 is probably going to be higher. 2021, we don't know. Deaths from drug overdose remain higher than the peak yearly death totals ever recorded for car accidents, guns, or AIDS. And this acceleration in the trajectory in recent years has pushed down overall life expectancy. And yet we continue to leave mental health off the table in our policy discussions. So that was before COVID, and we'll get to after COVID later. I'll turn it back to you. Thank you.
Well, so you're making my job easy as a moderator. My next question is about, is COVID bumping it up from 5 minutes to 10 minutes? How is it dialing up the attention and traction?
Well, great question. I think the one issue that all of us can relate to is that some of us probably didn't know what mental health was, or truly felt like, or even could name it before COVID. A lot of folks in this country couldn't. But there's one thing that I think everybody understands now is what mental health is. If you've been at home a year, if you lost your job, if you've experienced trying to manage your kids while you're on a Zoom call, all of these things do impact your overall emotional health. So we've actually come to a place where mental health has got to be named. And actually, a good example of where we're starting to see it elevate in dialogue is the recently confirmed Surgeon General, now second time around, Vivek Murthy, has already highlighted mental health and substance misuse as a priority for the Surgeon General's office, which is really great. Now, the themes that we've seen that have made it easier to talk about mental health as well is around technology. And it's really about access and tech. And so through the public health emergency order, there was actually the loosening of restrictions around what could be done for telehealth. And this allowed for a variety of different people to actually use telehealth services that had never been before. And the data, which we did a paper on this just recently, to a small reminder here, telehealth is not a new concept. It's actually been around for a long time. The first reported case for mental health was in the 60s, and it was in Nebraska. And it was a closed circuit television connecting a doctor to a patient. So it's not new, but nobody used it. And so until now, we saw this massive spike, 54% increase use of telehealth from 2020 to 2019. So just in 1 year time, 54%. And mental health, by far, of all the medical specialties, of all the specialties in healthcare, was using it the most. So that's changed, right? We've had this public health emergency order. HHS has allowed for more flexibility. We've seen people have access to their clinicians on their devices. And we've seen the loosening of those restrictions, including audio only, which was not allowed before, where you can actually just talk to somebody without having to see them. That has changed a lot of people's ability to be able to get access to mental health. So there's blessings that have come in us talking about it, especially when it comes to technology. There's also some curses, which we can get into if we want. The downside of what it looks like when you are siloing care again. Instead of teams, it becomes a one-on-one type of relationship with telehealth. So last thing I'll say, and I'll turn it back to you, right now in Congress, this is still being debated. Senators Tina Smith from Minnesota, Lisa Murkowski from Alaska, they introduced a bill, Senate Bill 660, which actually requires private health plans to continue to cover mental health and substance use disorders, regardless of whether they're provided in person or via telehealth. That's a big deal. There's an e-prescribing addiction therapy service. It's actually called Telehealth Response for E-Prescribing Addiction Therapy Services, which we love acronyms in policy. That's the TREATS Act. And that's actually going to eliminate the in-person exam requirement to allow for providers to prescribe certain controlled substances like buprenorphine for opioid use disorder. So these have not, we don't know when the emergency order is going to expire, but right now Congress is doing everything that they can to try and make these changes permanent.
Thank you, Ben. And we're delighted that Bree has found her way back. So I'm just going to pause the regularly scheduled panel to have you introduce yourself, Bree, and then we'll resume the panel conversation.
Thanks, Elizabeth. The tech goblins got me too, apparently. Sorry about that, everybody. My name is Bree McLaurin, and I was born and raised in Montana, and I'm currently living in my hometown of Helena, where I'm also raising my 3 children. And so it's an honor to sit on this panel today to share about our policy change efforts happening in Montana. I've been working in the field of maternal and child health as a registered nurse for over 15 years, and I've worked in home health, pediatric primary care, public health home visiting, and now I'm the executive director of Healthy Mothers, Healthy Babies, the Montana Coalition. Our mission is to improve the health, safety, and well-being of Montana families by supporting pregnant women and children ages 0 to 3. I love my job as the ED of this organization because it has allowed me to use my personal and professional experience. I am a postpartum OCD survivor 13 years ago, and so I blend all of my experience working with families and my own experience where I was one that also fell through the cracks to work to make lasting changes for families in our state. Thanks, Elizabeth.
Thanks, Bree. All right, Isha, I've heard the pandemic talked about with 3 streams, the first being the virus, the second being the racial reckoning, and the third being the mental health effects that we are going to be contending with for a long time. We are so glad that class has been taking a racial equity and economic mobility lens to its work, its expanded work in maternal mental health. How have you seen the conversation change as we contend with the murders of George Floyd, Breonna Taylor, so many others, and the disparities and inequities in health and mental health that COVID has laid bare? How are you seeing that play out?
Thanks for that question, Elizabeth. And I'm going to state some of the obvious and also just back up what you and Ben were saying also about the pandemic. So we've experienced collective trauma through this pandemic, and I think particularly for Black, Indigenous, Latino, Latina people, and also for Asian Americans and Pacific Islanders, we continue to experience intergenerational, historical, and cultural trauma. And that has been emphasized by the police brutality and the structural and implicit racism that we've seen. And then also through the consistent and escalating violence against Asian Americans and Pacific Islanders beyond the killings of Ahmaud Arbery, George Floyd, Breonna Taylor, Daniel Prude, the list goes on and on. And I think this moment has really opened an opportunity for policymakers, but not only policymakers, for our partners. I've been able to have conversations that I have not been able to have in years prior, even though I'm saying the same things. and also with funders to truly think about what this means for policy. And coupled with these exacerbated mental health conditions that Ben was talking about, this really makes this time a pivotal time to be thinking about the intersections of mental health policy and racial equity, what this means for communities of color, and what this means in terms of barriers for communities of color. So in legislation and in the administration, there's more attention being paid to the intersections between maternal mortality and mental health. You have all mentioned, that there is a greater attention being paid to maternal mortality, but this intersection between the two and what this means for women of color is really starting to be more of a conversation. And then in terms of prevention, and when we're thinking about the social determinants of health, as the panelists mentioned a couple of days ago on the first day of the summit, and then what this means in terms of access to healthy living, whether it's the environment, access to green spaces, access to clean water, culturally sensitive health programs, education and housing, and how that intersects with maternal mental health. And so in legislation, there are pieces of legislation that are more comprehensive, and that includes the Momnibus and the Moms Matter Act. And also for many years, we've been pushing the Health Equity and Accountability Act, which includes some of these bigger pieces of what needs to happen beyond our health access and our being able to access in order to thrive. And then also there are bills like the Health Equity Access, Resources and Treatment Act, the HEART Act, which Senator Cardenas just introduced. So there's besides the federal work that's happening, amazing work is happening on the state level, which I don't need to tell many of you who are listening, with the reimbursement of doulas, that those are conversations we weren't having a couple of years ago. I was able to be on the roundtable talking about that yesterday. And then there are quality measures that are inclusive of racial equity, and then including moms with lived experience at tables like perinatal quality collaboratives. That's happening in Pennsylvania. Thinking about maternity care bundles that are thinking about paraprofessionals, not just your OBGYNs. So things are starting to shift, but we really need to see more solutions that give space for the incredible culturally responsive work that's being done in maternal mental health. And now is the time for us to push. So thanks for that question.
Thanks, Isha. I'm going to move back to Ben. So policy work can be a long game. We are talking about a window of opportunity we have now, but we know some efforts will take years to pass and then more years to implement. But we talked about how people need support and services and care sooner rather than later. The Wellbeing Trust released a report titled Healing the Nation, Roadmap to Address the Future of Mental Health and Substance Abuse in the US. For our audience, the executive summary for that report is available through the Whova app. As we work on the long-term change that we need to always keep our eye on, what does the report offer as some more immediately actionable suggestions for helping people now?
Thank you. And we called it Healing the Nation. And just to reiterate this point, because per every comment that's been made thus far, our nation was in pain, whether it's through systematized and structural racism, through adverse community or childhood experiences, whatever the trauma might have been, our nation was hurting. And so in order to actually move forward and do something meaningful, whether it be through policy or some other mechanism, we needed to heal. So that's why we called it that. Now, in Healing the Nation, probably the most tangible thing that could be adopted that's not a major federal policy change or regulation is simply around the adoption of a vision that mental health actually needs to be in the places that people are. That's why it's not just a policy document. It's actually a framework too. And it's a framework that we open up. And for those of you that are interested in this, we're going through this process right now where we actually want it to be a framework that gets utilized by other organizations and not just the one that we, ourselves are using. It's something that we can all use, because in it is an opportunity for state policymakers, for local leaders, for our mayors to actually have tools and an understanding of the comprehensive and connectivity that's inherent when we actually bridge community to clinical. And let me just give you one example of that. So I've talked about integration. And one of the practicalities that we have within the framework is we look at all the places for engagement that we can have for a person and their family. And it's the places that we all know, right? There's the obvious ones like healthcare. How do you make sure that mental health is embedded within an OBGYN practice, within a pediatric practice, et cetera? But then there's the things that are less obvious, like what does it look like to really have a mental health clinician on site at your place of employment, so that you actually create a new structure that destigmatizes how we can actually get access to mental health services. And we go around the room, we talk about schools and criminal justice and everything else. To me, the most tangible, practical thing that we can do is to connect on a vision of what good should be. That's why we call it framework for excellence, because well, first of all, who wants to put out a framework for bad, right? Nobody does. But in the mental health space, there is a lot of tinkering that's done on the back of programs. They're well-intentioned. I don't want to have any disrespect for programs, but the problem is we've not got to the place of structural change. We've not addressed some of these fundamental underlying issues that are grounded in our community that are much more foundational for our overall mental health and well-being than just another program that might, yes, it will help a few people, but it's not going to change the structure of how we think about health. So that would be one thing. I hope that's not too big. You can take a look at the link yourself and see what you think about the framework, but thank you for the question.
All right, and speaking of reports, CLASP recently released a report titled Advancing Equity in Maternal Mental Health. And audience, this is also available through the Whova app. Isha, for those of us who like the wonky administrative policy work that involves state Medicaid directors, the report lifts up a couple things that they could do to better support maternal mental health. Can you share some of those recommendations with us?
Sure, Elizabeth, thanks. So with the report, we really tried to highlight how state Medicaid agencies can think about the systemic racism that exists in systems across the board, and work to address the racial inequities that will eventually lead to closing the gap, ideally, in inequities in maternal mortality and maternal mental health. So we broke this down into 3 areas. So first, we spoke about how state Medicaid agencies need to work with MCOs, with Medicaid care organizations, with health and social service providers, and with the community, with people who are impacted, to improve data collection. So not only data collection, but also data analysis and how data is stratified across demographics. So demographics not only include race and ethnicity, but also includes income, disability status, sexual orientation, gender identity. So to think about the broader picture of who is accessing Medicaid. And then the second bucket is to use an equity lens, for state Medicaid agencies to use an equity lens to better understand who is enrolled in the Medicaid program. And that really, it goes beyond thinking about implicit bias trainings of staff, but really trying to ask people with lived experience to speak to their experience and to truly think about beyond, using the term racial equity and checking a box. And then the third bucket is to use collaborative strategies with payers, with providers, and with community partners, again, to develop a framework that works for the state, to determine how to data share, because often, of course, that is often a problem between agencies on the state level, and determine what collaborations, what meaningful collaborations, and how can trust be built in order to incentivize incentivize equity in value-based care. So that will translate into payment reform, payment methodologies. And I really liked a framework that was used in an earlier panel too, like thinking about value-based agreements too. So trying to figure out, how can it be a true partnership?
Thank you. Well, now I'm going to bring Micah and Bree into the conversation. What I've heard from people working at the state level, or like I said in the intro, everyday birthing people, parents, moms, like what you're doing at the national level and in think tanks and in the Beltway, that's all well and good, but often it doesn't trickle down in the way we assume it's going to the states or to people who need help and support. But in many cases it does. So from where you sit in Georgia and Montana, from what Ben and Isha shared, what resonated most with you and the work you're doing and the people you serve?
So I can start off. I think, so much of what they shared is what we, want to see at the state level. And, for some of us that have been in this fight for quite some time, we know that it's often one step forward and two steps back. And it's a tireless space from the advocacy. So to hear these things happening on the federal level oftentimes is, very encouraging for us. But and again, as you mentioned, Elizabeth, sometimes it does feel like there is that disconnect, but, we try to do our best in terms of plugging into what's happening on the federal level. Certainly, I loved when Isha mentioned, incorporating, different frameworks that include folks like doulas and other paraprofessionals, and that's so much of what, we want to see in the state as well, and have some state initiatives around. So I appreciated everything that they said, and I think we're modeling that, and then often looking to what's happening on the national level to support our work, and hopes that it will trickle down.
I think what resonated with me was a couple things. It's inspiring to hear the mission of Ben's organization, because it does feel like there's families that are hurting, and so it's an inspiring title. And we're just starting to hear wind of 998 in Montana, and it seems to be exactly what we need, an initiative to bring together all these kind of efforts around mental health. So that's inspiring. And Isha, your reports I've been referencing in Montana as we're bringing forward ideas for policy change. And so having those kind of resources are super powerful for us that are trying to bring forward strong ideas swiftly, especially in this time of the funding coming in from the pandemic relief. And what you said about trusting relationships and able to have these conversations is critical. And so I think having, kind of having that hope to build relationships from and dream together is what's happening, what we're seeing in Montana right now.
Thank you. Micah, you've been busy and successful. We'd like to see busy and successful coupled together, advancing policy in Georgia to address maternal mental health. Tell us about some of your successes.
Thanks, Elizabeth. So I'll just kind of start with PSI Georgia as a whole. We're fairly new in terms of our state chapter. We were formed in 2017, and our advocacy committee was actually formed in 2019. So within that time, we've done a lot, and I'm really proud to say we just have some amazing advocates that have been pushing this work in a state like Georgia. So that year in 2019, we advocated for a little over $1 million in state appropriations to implement a telepsychiatry line that will provide consultations to physicians, physician's assistants, midwives, nurse practitioners, nurses. And so the state approved those funds through the Department of Public Health. And in December of 2020, so just a few months back, Peace for Moms is what the line is called. The program was implemented. And so we look forward to, getting data and seeing how that's running now. But we were really proud of that. And basically the line will support clinicians caring for moms and families, provide health professionals with information so they can best treat their patients, and then train medical professionals to recognize and treat PMADs in their patients. So now that the line is in the state budget, we continue to monitor it amidst many cuts to our state, and each year since then we want to make sure that it remains in the state budget. So the funds also gave additional funds to PSI Georgia so that we could provide more trainings across the state to ensure mental health providers, doulas, nurses, et cetera, understand PMADs, but also providing some of those advanced level trainings for certification in perinatal mental health. So now that we're creating this infrastructure where providers, can call the teleconsult line, but then also if they are screening and they have the information, if we don't have enough providers in the states to send moms to, then that's a whole. So we're upping the number of trainings now that we can provide through that funding. In addition, we also added additional questions to the Pram survey, the Georgia Pram survey, which is the perinatal risk assessment monitoring survey that's delivered widely to our pregnant moms. And it's where we gather a lot of our state data on pregnant and postpartum women. And so before, there was one question on the survey and it was related to depression. And so we know that that is really small, and we didn't really have any data for the state. We know that this is happening, but we really didn't have a place to capture that. So now with those funds, we were able to add additional, which apparently adding questions to the Pram survey is very expensive. So we found that out through that process, but we were able to get those additional questions added. And so we hope to see data as early as 2022 from that. Most recently, in last year, we worked with a number of other coalition partners as a state to uplift the need for Medicaid expansion. Because Georgia did not expand Medicaid prior to 2020, moms were being disenrolled from Medicaid at about 6 weeks after delivery. This left, of course, a gaping hole in coverage for moms that needed follow-up in addition, we know that our state maternal mortality review committee has mentioned, several times the impact and that most of our maternal deaths are happening within that postpartum period. And then also coupled with, the impact of maternal mental health. So we were able to get an extension. We asked for 12 months, but we were able to get an extension to 6 months. So at least moms can have a little bit more time to ensure that if anything came up during pregnancy, they still have that coverage afterwards. And so that was a huge success, and we're continuing to push for 12 months. I don't know what happens in other states, but in Georgia, typically things happen at a very turtle-like speed. And so you inch one thing and often we are tired of asking for crumbs. We want the whole cake, and it's difficult, but we are going to continue to push for 12 months, as well as we are looking at and supporting broadband access. And I think Ben mentioned this earlier as well, but a lot of our moms in rural parts of the state, of course, may not have access to broadband in order to have some of those telehealth appointments and those sort of things. So that's another thing that we're supporting and continue to push in our advocacy efforts.
And speaking of the whole cake, what additional slices are you planning to go for in the next 2 to 3 years?
Yeah, so universal screening is, it stays on our legislative agenda, and we just keep it there right now, but we're ready to ask for that whole cake rather. And so we know we want to build, that takes a lot to build up to. So part of that, we want to build, again, that larger state infrastructure network. We're looking to create a maternal mental health task force within the next year. And so we've already begun some preliminary conversations with the state, with the Department of Public Health regarding it. We know we need to bring key players to the table as a task force to start this universal screening discussion. And we also know that support like the creation of case management programs that helps mom find accessible care once they're OB screened and develop a treatment plan, that's also necessary and one of the goals of the task force. So universal screening is, certainly a part of that big cake. And we want, we just see that task force as like a starting point and bringing some of those key players in to make that happen.
Micah, shifting to Montana, we'll travel around the country a little bit. For the past 16 years, Montana was governed by a Democrat. In the 2020 election, it shifted from a purple state to a red state. What does that mean for Healthy Mothers, Healthy Babies policy strategy?
Thanks, Elizabeth. I think we're still learning, honestly. We're deeply red now, so we are expecting significant shifts in all things health and policy. Just yesterday, I was testifying at our Appropriations Committee meeting about accepting the ARPA funding coming in from the Relief and Recovery Act. There's talk about sending some of it back. There's fear of planting an acorn and growing an oak tree that we later have to support. So in my experience, planting oak trees are a good thing, but I think there's yet to know kind of exactly what to expect. Some things we do know, though, that is inspiring and hopeful is that our current governor is really interested in substance use prevention and suicide prevention strategies. We recently passed the legalization of recreational marijuana in Montana. And so there's talk of using prevention dollars to hopefully target upstream prevention, which we're advocating for at Healthy Mothers, Healthy Babies. We know that postpartum depression is the leading cause of toxic stress for children under 5. And if we take that kind of strategy, Trojan horse maybe, bridge maybe, but we're really hoping to just really go in strong with the understanding that one of the best ways to prevent later health and social challenges is to support healthy pregnancies and supported early childhoods. So we're hoping that we can be strong in that area with our new leadership and taking that strategy. But something we do know for Montana is that it's actually a really fun place to do policy change work because we all know each other. We might be big in distance, but there's just a limited number of us in these positions. And so we've grown to be good friends over the years. And Healthy Mothers, Healthy Babies, we're the only nonprofit in Montana that focuses on healthy pregnancies in 0 to 3 age. And we've been around for a long time. We came up through the national HMHB network and have been independent when that network moved into, I think they moved to 0 to 3 Foundation. But so Montana's been working independently since that point as the state partnered nonprofit. And so we've got great relationships in the medical community with community-based agencies promoting things like safe sleep, home visiting, and then our state partners, both in Medicaid and in the health department, and in services serving adults with mental illness. And so we're kind of in a great place right now. Progress moves at the speed of trust in Montana. And so we're really lucky that we've got this great foundation of people that we can think through progressing maternal mental health policy with. A big piece of what we do is supporting local coalition work and trying to elevate the voice from different communities across the state, including our tribal communities, and bringing it up to the state level so that the policy work is informed by people on the ground. And then vice versa, trying to communicate the initiatives from the state into the local communities to bring opportunity. Some of the things we hear is the need for training, the need for resources, knowing the local resources, and the need for more groups and peer support. So we've been working really hard to address all of these different issues. We host an annual conference now where we try and bring in kind of the most innovative new speakers and ideas to inspire our workforce to learn together and address some of these issues that are connected with perinatal mental health. We are promoting the PMHC credential. We're working with our partners to bring in as much training as possible so we can grow those numbers. We have this really neat organic kind of grassroots group peer support network growing, and where we're identifying survivors of anything from infertility, trauma, loss, postpartum depression, kind of just a big gamut across the parenting spectrum, and looking for both rural and urban different experience people to host these groups, and then working to help promote them in a systematic way so it's easier to find help when you need it. And something that we're really excited about is addressing this whole universal screening barrier. We kind of started hot from the trot and created this screening protocol and brought in all the recommendations from ACOG and the task force, and brought together a group and put together this really neat screening protocol that I think is in HUVA. And then we realized that there is just a lot of barriers to universal screening because there's a strong value that you shouldn't screen without knowing the resources. I disagree with that because I'm a survivor and I didn't know what was going on with me, and it was really scary. And so I'm of the feeling that people that are suffering in silence should be able to put words to what they're experiencing and understand that there's treatment. But that aside, there's a lot of other opinions about that. And so to overcome that barrier, we've started working with many partners across the state with several. It's a really neat collaboration between multiple grants and multiple partners. And so we're mining our P3 supports, we're calling them, pregnancy through age 3. Everything from doctors to groups to libraries to SNAP benefits, like everything we can think of, and trying to make it accessible and easy to find based on location. And so then also the plan is as these national resources come, and so the justice system is not called necessarily when we get a 911 for a suicidal mom, and instead we get a trained mental health provider, that those resources are accessible. We're trying to create this open sourced list. And so we're really excited that when we have that list, that we can come back to some of our providers that really feel like it's not the right thing to do to screen without a resource, and say, here you go. Now will you? And so that's really the exciting thing. So by the end of the summer, we should have this project done, and we're building an application on our website where you can kind of sort it. And we want it to feel like traveling. We want it to feel like fun and empowering to look for support. So I think the last thing I'd like to mention is that we're doing a lot with storytelling. We're really trying to empower our Indigenous women to lead us through their experiences, and we were able to host what we understand is the first ever Indigenous perinatal mental health panel in Montana at our last conference. And while our groups in person are on hold, we are trying to do things where we can bring people together to do simple embroidery projects and host local conversations. And then lastly, we started a podcast where moms can tell their stories. It's called Mother Love.
So many awesome things happening in Montana. Thank you, Bree. We're going to begin to close out the panel. a lot of mental health policy work involves passing new things and looking toward innovations, but we also have to fix things that are broken. So my last question for all panelists has to do with, what would you fix if you had a magic wand? So I have my magic wand. It's kind of hard to see. It's a wooden spoon. It's because I cook for my family, but the secret is that it has a unicorn tail hair in its core powering it. And so the thing I would fix as I wave it would be, as a funder, I see the need for more funders to join in supporting the good work that you are doing. And so I would use my magic to make that happen. I'm gonna go in reverse order. So Bree, Micah, Isha, and Ben, what would you do with your magic?
Lucky me. Okay, I'm gonna use a frozen Valentine for my magic wand. Paid family leave. As a home visitor, it was absolutely the most heartbreaking thing ever to see women have to go back to their jobs to maintain their housing or whatever. It's just not fair.
Yeah, and just to chime in on that, I forgot to mention paid leave. We just yesterday, we had a paid leave bill passed in Georgia that it's only for state employees, crumbs. Okay. However, we're excited for state employees and we see it as a first step. So I would have said that, Bree, previously, but I think I'm just going to throw some extra seasoning of that funding in, and I'm going to say multi-year fundings, and so that we can, not only like come together to think of these great ideas, but we can like implement them and see how they're going. So I'm going to say multi-year funding for maternal mental health and policy work.
My magic wand is a candlestick, so I can light it on fire too. So I would also agree with Bree and Micah and say paid family leave. I don't know if you all saw, New Zealand is also, the parliament just passed legislation, which is likely to pass, getting family leave for women who've experienced child loss or miscarriage. So I hope that we go in that direction as well. And then I would also say beyond the extension of postpartum Medicaid, that's fantastic. It's a start, but there needs to be better reimbursement for services that are more comprehensive, and particularly thinking about women experiencing maternal mental health conditions and also specific to women of color.
Well, I'm going to use my magic unicorn my 6-year-old painted for me that's never been on a national stage before. So thank you for allowing me this moment to use this. It's a mermaid, not a unicorn. Sorry. My two things, since you all used your wonderful wishes on things that I would want to, I will just go really big and say, I think that we need to have universal coverage for everyone, everywhere. And two, and this is a little bit controversial, but we know that it does impact on overall mental health and well-being. I think that we need to consider some type of universal basic income so that we can get ourselves out of this horrible place that we've gotten ourselves into with poverty in this nation. Because if we really want to see people thrive, we really need to figure out that problem too. So that would be my use of the mermaid today.
Well, this concludes the What's Next for Mental Health Policy panel. I want to express gratitude to each of our esteemed panelists and to thank 2020 Mom for this amazing virtual forum. And with that, I will turn it back over to 2020 Mom.
Great. Thank you so much, Elizabeth and panel. Wow. Thank you all for your incredible and important work and contributions via white papers to the field. And also thank you for your energy and the work that you're doing on implementation. You give us hope and ideas for implementation. I wanted to also just acknowledge, Ben, that a mom probably would have noticed that that's a mermaid and not a unicorn. I love that. I think my husband would have said the same thing. And thank you all.